Hello, it's Michelle Morand here with Cancer Just the Facts. And today I'm going to share with you an interview with Dr. Razelle Kurzrock. Dr. Razelle Kurzrock is the Chief Medical Advisor and co-founder of an organization called CureMatch. CureMatch we're going to hear all about in a few minutes. It helps patients and their doctors ensure that patients are getting the right treatment as quickly as possible for their cancer. So we're going to hear about how it works and why it's so important. We're also going to talk lots about current diagnostics for cancer, what is done in standard care versus what is possible in precision cancer medicine. We're going to talk about targeted therapies and a number of other things in this interview. But I wanted first to tell you a little bit about who Dr. Kurzrock is, so you appreciate how exciting it is that we get to learn from her today. Dr. Kurzrock is a world-renowned physician scientist leader in precision medicine. She has developed novel therapeutics in the field of oncology. She has founded, developed, and chaired one of the largest phase 1 clinical trial departments globally through MD Anderson Cancer Center. She is a pioneer trialist of the Winther trial in precision medicine, which for the first time focused on transcriptomics and genomics. At University California, San Diego, she led the Center for Personalized Cancer Therapy and Experimental Therapeutics program. She founded a rare tumor clinic and signature iPredict study, which matches combination therapies to patients. She has over 800 publications on PubMed, which is the clinical trial database or publicly reviewed, peer-reviewed journal database, and an H-index of 125. She is named on the list of the most cited scientists in the world and on the list of 25 most important voices in precision medicine across the globe. And we're about to hear all about her new project, CureMatch, and about her take on what's coming for precision oncology and for cancer patients, and most importantly, how you can make sure you're getting the best cancer treatment right now. So I hope you enjoy the interview. And if you have any questions for me or Dr. Kurzrock, or want to find out more about how to apply genetic testing, CureMatch, precision oncology to your cancer care, please just post in the chat or send me an email. So today, we're going to hear about what CureMatch is, how it helps people, and why, as a cancer patient, it's something you definitely want to make sure you're adding to your decision-making process for figuring out what treatments are going to be best for you and, when it's time to make a change. Dr. Kurzrock, welcome.
Well, thank you for speaking to me, and I'm really excited to talk to you about CureMatch and maybe give you a little bit of background about the journey to get there. And I'm a medical oncologist. I'm from Canada originally, from Toronto, but I've spent now a lot of my professional life as a medical oncologist in the United States. I have been a department chair at MD Anderson Cancer Center, and more recently heading up the precision medicine program at University of California, San Diego. And what we've seen in the last decade or so is really a transformation, or the beginning of a transformation in cancer care. And this is taking place because of the technologic ability to do genomics and transcriptomics and look at each patient's tumor in depth. But as these really phenomenal technologies that were probably unimaginable 15 years ago, have come into the clinic space, they've brought tremendous amounts of new information and potential, but they've also brought new challenges. And the challenge is that what the data has told us is that each patient's tumor is different, and each patient's tumor is extremely complicated. In fact, the analogy I make is to snowflakes, where every snowflake, the individual crystal structure is extraordinarily complex, and every snowflake is different from every other snowflake.
Mhm.
And so what we began to realize is that unraveling this complexity was really beyond human cognition. And we needed a method to unravel it. And so the way CureMatch was born is we actually started working at University of California, San Diego with the supercomputer system to develop a version 1 of algorithms, really to put all the data together in order to make best decisions from patients. And CureMatch was born out of that.
Mm.
And then CureMatch has spent the last few years really building on these algorithms. And I genuinely think it's got the strongest system anywhere for deciphering the complexity in any individual tumor in order to make the best possible treatment decisions for a patient. So I'll just pause there and
Thank
let
you. That's a wonderful introduction to yourself and to the origins of CureMatch. So to put it succinctly, as you just said, we've had this amazing development of technology, this genomic testing, the ability to look inside each person's unique snowflake, as you say, great analogy, and find out what's really going on in their cancer, what the drivers are, what the genes and the molecular analysis of this. And what you've done is you've created an artificial intelligence, a computer program that essentially gathers data from all the different journals, all the latest research. In my understanding of a conversation I had with Jennifer last week, this is something that gets updated almost on a daily basis. It's that current.
It absolutely gets updated, yes, on a daily basis.
Which is really exciting. In and of itself, that excites me as a cancer care advocate, because it means that it's not, it's not months old. These people who are getting this report from you, and we'll talk more about what's in the report and how to get one, but the folks who are getting this report from you really are getting the most current medical science information about the genes and the treatments for targeting those genes that are available now. Maybe we could talk a little bit about would you be willing to tell us a little bit about targeted therapies versus, I'm reluctant to use the word standard cancer care, because of course that's morphing and growing, and this is becoming standard of care excitedly. But how would you define targeted therapies or the types of treatments that we can now access because we have this genomic data? Why is that so important?
So I think that along with having the genomic data over the last few years, treatments have been developed, drugs have been developed that specifically target abnormalities in the tumor. And they've been developed in such a way that they're like smart bombs. They target the abnormality in the tumor, and they don't cause a lot of damage to normal tissue. Now, I want to say that I still believe in chemotherapy, and chemotherapy has an important place as well in treating cancer. But what we can do now is we can analyze and pick which patients are the most likely to respond. The reason that chemotherapy historically got a bad rap was not because it didn't work, but maybe it worked in 20% of patients. And then the other patients would have the toxicities. And we couldn't do any better because we didn't have any tools to be able to differentiate which patients might respond to chemotherapy or might not respond to chemotherapy. So these genomic tools now give us, it's not perfect yet, but we're really on the road and we can really see the difference. And this is even more true for targeted therapy, where the drugs have been specifically developed, as I said, like smart bombs, to target the abnormality and leave the normal tissue alone. And that has the potential to minimize side effects. But it also means you have to pick the right patient, because if you give a targeted therapy to a patient that doesn't have the target, that's going to be almost completely useless. And that's actually, I also want to mention, that's also very important for immunotherapy.
Yes.
So we're all very excited for immunotherapy, and for a subset of patients, they have phenomenal responses. I've seen patients that were on their way to hospice, and now they're 5 years out and disease-free. In fact, I'm almost hesitant to say as an oncologist that they're cured, but I actually think they're cured. But the important point here is to have, again, the tools, which are genomic tools, that pick which patients are the most likely to respond to immunotherapy and which patients are the most likely not to respond or even have side effects or problems with immunotherapy. So the whole idea here, and it's actually a simple idea, but instituting it is very complex. The idea is that we pick the right drugs for the right patient, that we don't just randomly give patients drugs, that we understand what is wrong in an individual tumor. We put that data through the CureMatch system, and we figure out which drugs are best for that patient. And a lot of times it's not just single drugs, but it's a combination of drugs, because cancer is tricky. It might have many different ways to grow. So we want to hit it in as many ways as possible. In order to get the best results.
Yes, as we see often, genetic tests come back for people, and they can have commonly 5, 10, 15 mutations that are involved. In some cases, some that had very excellent response to immunotherapy, as you're saying there, one fellow had 200 mutations come back on his report. And that's not a bad thing necessarily, because this person years later is also cancer-free at this time. So it is really exciting. As you say, the concept of finding out what's going to work and administering it on the surface is simple, but here's where CureMatch comes in, because now that we have this genomic testing, and in 2022, it starting to become better understood and accepted by medical oncologists on the front line as a very important tool. I appreciated what you were saying also about chemotherapy, and so many of the new treatments that are really providing such great benefit to people have low doses of chemotherapy plus 1 or 2 targeted therapies. So people aren't having the side effects of chemotherapy. And I think it's great that you made that point. It was all we had. And so it did its job really well. And for some people now with the right genes or the right molecular background, it can be exceptionally beneficial, and the side effects are practically nil. And with these targeted therapies and the low dose chemotherapy, we're also seeing similar outcomes, which is excellent. So if you're out there listening and you're thinking, chemo, no, remember, you're probably thinking in an outdated way about chemotherapy. As Dr. Kurzrock mentioned, lots of folks it didn't work for, or it gave them some pretty powerful side effects. Whereas now when you're stratified and you know it's right for you and you've got the right combination, you won't almost certainly experience the side effects that we all think of when we think of chemo. So don't poo-poo it if your doctor mentions it. Just make sure that you've got the genomic testing and that it's the right one for you, for sure. But there's so many other things aside from chemo now. There's so many different targeted therapies and off-label therapies and the immunotherapy that you're mentioning as well. So let's go to really the reason for CureMatch, which is this information bottleneck, I call it, that we have now so many genes that can be tested for. Right. In RNA overexpression testing, you can look at 20,000 genes. Commonly used tumor-based DNA tests look at anywhere from 350 to 600 genes. And not all of those have targeted therapies yet. We have a long way to go with that, but the most common ones do, and many have numerous different targeted therapies. But we have oncologists who are they have large practices. They have about 15 minutes per patient as a rule. What's your what would you like to say about oncologists' workload and the time they actually have to review data for each patient? What's your knowledge on that?
So I think that you've hit the nail on the head. Unfortunately, cancer is a very common problem, and I don't think the oncologists there's any way that they can review all this genomic data. I actually don't. I mentioned this before, but I don't think any human being anymore can review all
Yeah.
this data. So, for instance, if there's 300 drugs available for cancer patients, if you look at 3 drug combinations, that's 4.5 million. And then you layer on top of that hundreds of thousands of different variants, and you're talking about billions, maybe more than billions of pieces of data.
Mhm.
No human being can analyze that at this point.
Right.
And that's where CureMatch comes in. We've worked on the system now for over 5 years, and we input all the data. We have a system that can then decipher the data and give the oncologists with a score the best match for each patient. And we typically give 3 drug matches, 2 drug matches, and 1 drug matches, and we score all them. Usually the 3 drug matches have the highest scores. We can score specific drugs if the oncologist thinks it's an appropriate drug, so the oncologist can see how well their regimen might score as compared to our optimized regimen. But the bottom line is that CureMatch has resolved the complexity problem.
Yeah.
And
That
that
information bottleneck. Now there's a way to quickly get all of those pieces of data working for you, making sure that all the variables that need to be considered about the mutations that are involved in your cancer and other key elements are all being factored in to come up with this list, as you say. I also really like that. I'm always thinking education and big picture and everybody using this as quickly as possible. And I love the fact that you give doctors the option to put in their best guess. I see that as a great opportunity for education for doctors about, how close to the bullseye did I get it? And if they've used your report a few times, they will start to see, I'm probably a little bit off every time.
I think that's really important, but it's also important because the doctor knows the patient, and they not only can they put in their best guess, but they may want to say, I'm not going to, here is some drugs that I'm not going to use because the patient has heart disease or some other reason that the doctor feels that it would be contraindicated to use certain drugs. So we can substitute those drugs, or we can simply take them out and give the best, because the doctor knows the patient. And so we can give the best match omitting certain drugs if the doctor feels that that drug may be a problem for the patient for other reasons, kidney disease or heart disease or whatever other health problems the patient has. So there's a lot of ways to customize the report. And then the other thing I want to emphasize is that the intake can be any type of genomic testing. So we're not wedded to
Tumor DNA or something.
right. It can be DNA or RNA, and we're not wedded to one specific company. Whatever testing, and it could be that a patient has multiple tests done. We've seen patients that have gotten test results from several different vendors. We can input all of that. So the more data for us, the better. And we're not restricted to data from a certain format or a certain company.
Excellent. So let's just recap what we've covered. We've covered really the evolution of cancer care to where genomics is the way to go. Getting that information is just understood to be a critical piece of making sure you're on the right treatment. We've talked about how many different genes there are that can be identified or slight little variations on that. and how many different treatments already exist, and more are coming out all the time for various of these. We've talked about how oncologists, and no human, not just oncologists, has the time to actually research all this for any one person. The question I have then is, okay, so now we have this bioinformatics automated intelligence program that, and you're saying the intake. So let's talk about that, is what I'm trying to get to here. So let's say I'm Mrs. Smith, and I want to use CureMatch. Can I do that myself, or does my doctor have to do it?
So I think we prefer that it be done through the physician.
Okay.
What the input we need is whatever tests have been done.
Okay. Right, because what you're saying is, I guess that's what I'm trying to get to with the intake. So folks, certainly we can help with this, your doctor can help with this. And because there's information from the genomic testing that needs to be inputted, you kind of need to have a bit more knowledge than the layperson might have in order to make sure you're entering that data accurately. Is that really what you're getting at?
I think so. I think it's best if, and also we want to have all the data,
Right.
all the data,
Yes.
all the different genomic tests that have been done.
Right.
We would prefer the more data that we get in from what testing has been done.
The more you can hit that bullseye.
Right.
Yeah.
So a lot of people feel like when there's more than one test done, it's too complex. It makes it even more complicated. For us, it makes it even better.
Yes.
The more data that we have, the better our reports. But we're set up to really generate the reports pretty automatically. The system is extremely sophisticated. And what I think, again, I don't think human beings could process this data.
It doesn't sound like it, not with those numbers of possible permutations. And why should you? Really, because the cost of this test is about $1,500. This is US.
It's US dollars.
Yes, just double checking as a Canadian, always hopeful. So 1,500 US, folks. Really, for all the, in my experience with how much time it can otherwise take, and as you say, you can still never cover all the bases that your program could if you're trying to research all of the genes that turned up in some of your testing. Certainly it's a day or two, isn't it, for your program to work its magic once the data gets inputted. It's quite speedy.
We usually return the reports in about 48 hours. Okay. Actually, we can generate the reports much faster than that, but we cross-check everything that we do to make sure.
Well, lives are on the line, so it's worth being extra careful, isn't it?
Yes, but we usually turn it over in about 48 hours for patients.
Right. So if as a cancer patient, you're thinking, or you're you've educated yourself to the point of understanding the value of genetic testing, molecular analysis to help inform your oncologist treatment decisions. CureMatch is a way. So if we think about general genetic testing or molecular analysis is getting you in the ballpark, and then you have this program that's going to take all the data from the ballpark, plus, as Dr. Kurzrock was saying, information about, are you missing a kidney? Do you have high blood pressure? What are some other chronic health concerns that might influence whether you would be a good match for a certain treatment, or whether your doctor would feel comfortable prescribing that for you? All of these things you can enter into the program, and that gets factored into the recommendations that are made.
Yeah, so we factor in multiple levels of information. And I mentioned that if there's 300 drugs in oncology, that there's 4.5 million 3-drug combinations. Obviously, nobody can do that in their head, or at least nobody that I know. But But and we can actually calculate a score for all 4.5 million, but usually people don't want that. They want the top 3, or we actually give the top 9 possible combinations. But if the doctor or the patient then has questions and wants to look at any combination, we can generate a score for any one of the 4.5 million combinations.
That's the exciting thing too, is because it's a bioinformatics program and not an individual, you can update. We've had that experience too when we tested this out, with Alex giving you a few variables and then realizing he wanted to add a few more. And I realized that's not ideal and you want all the variables up front the first time around. The point is, if you get new data down the road, you can add that in and the program can update what's been done or
Absolutely.
what's going to be best for you. I'm curious, when genomic testing first began to be a thing, we'll say 12-ish years ago, give or take, there was a lot of assumption that people's mutations change rapidly. And so if I got a test today, but I wasn't really looking for a new treatment option for another 6 months or a year, that would be like way out of date and pointless. We now know that that isn't the way it goes. While there are some variations, what's your knowledge of how your own individual genetics that are influencing your cancer might change over the course of the years that you have the disease?
So we do know that it does change, but probably about 80 or 85% of the alterations remain stable. And probably about 15% will evolve with time. And they can also, by evolving with time, they can also cause resistance. So one thing that I do, for instance, for my patients is I will sometimes rebiopsy a growing lesion, or I will get a liquid biopsy. I will get a blood test to see if there's new mutations which have occurred. But this is also another reason to try to do a combination of drugs that is best suited to the tumor right at the beginning, to hit the tumor hard right at the beginning. And again, these drugs, especially these target new drugs, they can hit the tumor hard without hitting the normal tissue.
Yes.
And that's really what we want to do, because the harder that we can hit the tumor right at the beginning, the less chance the tumor has to evolve resistance. But if the tumor does evolve resistance, again, in my own practice, I'll rebiopsy the patient, or I'll do a blood NGS test as a follow-up, and then we can rerun the reports that incorporate any new data that has emerged from that, so that we can improve on the regimen.
So let's say you've identified in your initial testing 5 key mutations that you're keeping an eye on. When you do retest at whatever point down the road, would you just test for those 5, or would you do a broad sweeping test again?
You do a broad sweeping test again.
So
I think that's critical, because we cannot guess what the tumor is going to do. And I say it's half jokingly, but I've heard people say, well, the tumor never does this. And I can't tell you how many tumors I've seen that didn't read that book. And
yes, they didn't know they weren't supposed to.
Don't know that they're not supposed to do that.
Right.
So I have a very strong belief that broad testing with several hundred genes is the way to go. I think sometimes people are reluctant to do that because it's complicated, but that's exactly our sweet spot.
Right.
And again, if you try to guess what the tumor is going to do, you might guess right, but you might guess wrong.
That's right.
Limited testing, I don't think that's good enough. I think we need broad testing, and we can't assume what tumors usually do. We don't consider any patient the usual patient. We consider everybody as an individual.
Yes, yes, because that's what cancer is teaching us, isn't it?
A-
Exactly. Yeah,
Absolutely.
the
Yes.
combinations of genes, they start, the snowflake analogy again is a perfect one for that. So here in Canada, we're struggling. We're a little behind for lots of reasons, which we won't go into today. But one of the things that I find frustrating about how cancer is treated in Canada is if genetic testing is used at all, it's usually only after the patient has failed all other options. It's not, it's, this is, I get so riled up about this because of everything you just said. You've got to hit it hard, hit it fast with the right stuff. And there's no way to know what that is if you haven't done this type of testing. And yet in Canada, largely small panels are used. So there might be like a colon cancer panel that has 15 to 20 genes or even 5 that they're looking at depending on the location. And that's it. And then the patients are told they don't have any markers. Sorry, standard care only, you don't have any markers based on 5 genes. The use of small panels here and the fact that, again, in Canada, largely patients are forced, unless they take it upon themselves to get this data and they can prove to their oncologist what they need, they're otherwise forced to go through standard first, second, third lines.
Yes.
Which is, as you say, potentially not just a wasting of time, perhaps, because we're guessing, but all of the side effects.
Yeah, so I think you've hit it on the head. The first thing I will say is that the reason standard first, second line therapy are standard is because they work for some patients.
Right.
But the advantage of doing broad-based testing is we can help pick those patients. Who is the standard? And sometimes the oncologists, even amongst the standards, our oncologist, when at UCSD would come and say, okay, I have 3 different standards. Can you help me just pick which of the standards to use in this patient? So the advantage of, I strongly believe that every cancer patient is going to get genomic testing from the time of diagnosis. I don't think we're
Yes.
there in the United States either.
Not
But
yet.
I think I think that's the future. And
How
then,
else could it be?
yes, absolutely. And then the question is, you need a large panel because there are a lot of rare mutations that are very important and can be targeted. Sometimes the drugs are extremely powerful. And I don't care if it's rare, if it's you want to know it's there.
That's right.
So it doesn't matter. And then lung cancer is a great example now. Lung cancer has multiple rare mutations, but if you count them all up, it's more than 50% of the patients that have one of the rare mutations. So even though individually they're each rare, this is why you need a big panel, because altogether it's already making up 50% of the lung cancer population. Now, I think one of the barriers for physicians being an oncologist is the complexity and the fact that there's so much information there. And I think this is really where CureMatch can come in. Some of the hesitation in oncologists may be in dealing with the complexity. We certainly saw that in our oncologists at UC. And so having a system that unravels that complexity for the oncologist, and again, I don't think this is complexity for any human being.
Right. Yes,
So it's
that's
not,
right.
and so having a system that solves that complexity, I think should make it also easier for the oncologist to embrace what the large panel sequencing, rather than thinking,
That's going to be
I'm
too much
getting,
information. I don't
I'm
have
getting,
time for that.
well, not only I don't have time for it, I can't unravel it. And we've unraveled it basically for the oncologist. And as you said, it's completely up to date, right? To the, I mean, we have such a great team. I'm sometimes so proud of myself, and I'll send them, did you see this information? And it just came out, and they're like, we already have it. how can you have it? It was just an
Oh,
hour
that's great.
ago.
That's a
So,
wonderful feeling, though, to know your team is so on top of that.
yeah, yeah.
Yeah,
So
yeah,
really great team, keeping up with everything.
great. I would love to get your sense. I think you and I have talked about this today already, but let's put a finer point to it. There's a lot of folks out there, if you're on social media at all. Certainly we get it all the time on our Facebook page. People saying stuff like, there's already a cure for cancer. They just don't want you to know. Or, they're just kind of holding it back for the money kind of thing. And I think what we've just talked about today is kind of the answer to that. But would you be willing to kind of put your words to what might you say to someone who says, there's already a cure, they're just keeping it from you?
Well, they're keeping it from me too. So,
Yeah. I know,
uh,
we're not in the club either. Yeah, but
uh,
really, like, given what we've just discussed, how
uh,
likely is it there's going to be one cure for everyone for cancer?
there's not one cure for everyone for cancer. That's I think if you really think about it, when we look at people, everybody looks different.
Yes.
Everybody is a different height, is a different weight. They have predispositions to different illnesses and so forth. And cancers are exactly the same. Each one of them is different. I cannot see even the possibility that there's a single cure for all or most cancers. In fact, I think we have the key now as to moving forward. I'm not going to claim that we're curing all cancers yet, but I think we're on the road now.
Yeah.
I will say in a way that I could never have said 20 years ago.
No.
And how are we on the road? Because we now understand, as I've emphasized before, that every cancer is different, every cancer is complicated, but I believe that we have the answer to unravel that complexity and give the right answer for each patient. And that data is really accumulating at a very, very, like, science is moving at such a rapid pace now. And that's what CureMatch does. It puts it all together. And so there absolutely there is not now, and I don't believe ever will be, a single cure for all cancers. But do I believe that cancers will be cured? Absolutely. And the key is to understanding each individual's cancer and giving them the right set of drugs. Through very sophisticated technology, which I think CureMatch is a great example.
Yes, I agree. Yes. So let's just wrap up with a little bit of tutelage for you watching at home about how you would get a CureMatch report. So would you like to lay out what would the steps be that someone would need to go through in order to benefit from what you've created?
I think the main thing is to work with the physician and contact the CureMatch team. And we have some of the team here, Jennifer Estrom and Carrie Cook, and we can process the report and get the answers back in 48 hours.
Mm-hmm. So it starts with, and this is where we can come in and give you a hand in terms of how to approach your doctor. And because in Canada, it's not so likely today, although who knows in a year, but not so likely today your doctor will have heard of CureMatch or know that this easier way of getting the information that they need exists. So we can certainly help connect you with that. But the key is working with your doctor to have them make sure that they're inputting the most important variables, that the data that does exist is being utilized to your best advantage. And then this report comes back within about 48 hours with the different treatment options listed, including, as you mentioned, whatever your doctor was thinking of giving you can be analyzed as well and listed, ranked as whether that is up near the top or something maybe to hold on to for later or not suited. And then from there, prescription and access.
Absolutely.
Yes, wonderful. So what kinds of, what do you see happening for CureMatch and yourself down the road? What's the
Uh,
big vision?
I think the big vision is to bring this potential to people really across the world. Um, uh, I I have no doubt that the cure match system is that every patient with cancer needs to be cure matched.
It
And
seems foolish not to.
yes, and
Yeah.
so what our vision is, we would like to see every cancer patient cure matched.
And we'd like to help you to have that vision too, because it's such an excellent program and provides so much actionable information. And one of the things to keep in mind as a cancer patient is your doctor is always doing their best for you with the information they have available. So what we're talking about here today is helping them to have more information, something more precise and stratified for you. So a lot of times your doctor might tell you this is the best treatment for you, and what they're really saying is, based on the information I have right now, this is absolutely the best that I can offer you. It doesn't mean that that is the best treatment possible for you right now. And it takes that genomic testing data and a program like CureMatch to actually have the confidence that you're getting the right treatment.
No, I agree, and I think you've hit the nail on the head. This produces more accurate, better information. That
Yeah.
is the bottom line.
And fast. This is what I just keep, I'm so excited about, because as you keep talking, it's impossible for one person to analyze all the possible data, even for one person. And certainly when we first started, Alex and his research team were doing this. This is 12 years ago, but we were doing this all manually. So it would be 30 plus hours per person that we would take to go through the most current journals and all the data and cross-analyze all the other possible permutations that you could do in that amount of time. And even then, yes, I'm sure options were left on the table simply because we didn't have access to all of that information or that time. So it's pretty exciting that, because genetic testing as a rule takes 3 to 6 weeks, depending on what kind of test you're doing from the time the facility receives your sample, whether it's tumor or blood. So another couple of days after that data is back, and you can have something that's even more personalized for your doctor to act on.
Thank you. I think they're great questions, and I hope this is helpful. Most of all, I hope this is helpful to patients.
Yes, I'm sure it will be, because you've talked about a lot of general information about what's happening with cancer care and why there's such good reason to be hopeful, all the possible treatment options that exist, and how to make sure you're getting the right one. So I think we've covered all the bases.